Thank you very much, and thank you to Samir and the rest of the organising committee for inviting me. It's always a hard task to follow Tom. He always gives a great talk full of data, to which he's adding his own insights, and some of what we've heard is really cutting edge. My job is to give you, in the next few minutes, some vignettes from the view of a jobbing clinician about pneumocystis, and I'm aware the audience is quite a disparate audience, so I hope there's going to be something that will interest at least some of you. I would start by saying one of the studies that Tom alluded to was the ACTG trial published by Zalopa, which was about the timing of start of antiretroviral therapy. And as Tom rightly says, it's 2 weeks is better than waiting 6 weeks. But I would urge you all to read the paper, particularly to read the online supplements, which include the exclusion criteria. You couldn't be in the study if you required IV treatment. You couldn't be in the study if you were anemic, thrombocytopenic, leukopenic, had a raised creatinine or abnormal liver function test. It tells us that starting antiretroviral therapy in the majority of patients with mild PCP is better at 2 weeks rather than waiting for 6 weeks. But whether it's better still waiting for 3 weeks or starting at 1 week remains the black box. Anyway, what I'd like to do is just briefly talk about what pneumocystis is called, review who's at risk of getting pneumocystis, talk a little bit about new diagnostics, hopefully building on some themes from yesterday. What's new on the treatment front? Well, it won't be a blank slide, but there is something to say. And finally then, what's the broader picture around pneumocystis? Pneumocystis in humans is caused by Pneumocystis jirovecii. It is no longer caused by Pneumocystis carinii. The acronym is still PCP, from Pneumocystis pneumonia. So if you meet a patient who says to you, "Doctor, I had Pneumocystis carinii pneumonia last year," you're talking to a rat. But the whiskers and the tail will give the game away. Pneumocystis carinii is the cause of Pneumocystis pneumonia in rats. Pneumocystis jirovecii causes PCP in humans. It's not PJP. Now, unfortunately, some editors of some journals insist on calling it PJP. The point I'm dwelling on is if you're going to search for information on pneumocystis, unfortunately, apart from putting in pneumocystis and PCP, you will also have to put in PJP in order to capture the literature. Pneumocystis is topical, and this lovely study from HPA showed a 7% year-on-year increase in reports of pneumocystis. And alarmingly, these were not in HIV populations, they were in other populations, hematology, oncology, and what was new in this study was a description of pneumocystis being overrepresented in people in the general population with chronic lung disease, whether that was bronchiectasis, interstitial lung disease, or severe asthma. Other reports in recent months, this report from a collective in France, shows there's a huge interest and awareness of pneumocystis occurring more frequently in increasingly immune-suppressed populations, here hematology and oncology patients. Here's another paper online at the moment, paper version still not out, in the American Journal of Medicine, again looking at groups of patients previously not thought to be at risk of getting pneumocystis. And then more recently there are descriptions, this one from Santiago, Chile, of pneumocystis causing a completely new disease, ventilator-associated pneumonia. So it really is something that interests me as a clinician, and I hope I can enthuse you a little in the next few minutes. So who is at risk of pneumocystis? We know, despite the HPA data saying the incidence within the HIV population is falling, that the total numbers are staying about the same. Certainly at our centre, one of the HIV treatment centres, we now look after over 4,500 HIV positive patients. Increasing number of patients are being diagnosed and treated for cancer, undergoing organ transplantation. The biologics are no longer the new kid on the block. They're an established part of the disease modification of rheumatological problems. And other general medical problems are also being treated with disease modifiers. But who is actually at risk of getting PCP? Now, Andy Limper I regard as being the world expert on pneumocystis. He works out of the Mayo Clinic in the States, He's a clinician, he's a co-author of the North American Fungal Guidelines, but he's also a fantastic basic scientist. And he and Eva Carmona spent considerable time reviewing the literature. Now, this paper's a couple of years out of date, but what they've done is they've identified who's at risk. So the easy bit, HIV-positive patients, if they're not receiving prophylaxis, not receiving antiretroviral therapy, the risk of them getting PCP goes up the lower the CD4 count. And indeed, we would offer prophylaxis pending starting heart if we met somebody with a CD4 count for the first time below 200. Irrespective of the CD4 count, if you're living with HIV and you have a lymphoma, you are at huge risk of getting PCP, regardless of your CD4 count. And going back, reinventing history, going back to 1981, 82, what a surprise. You see a patient in front of you, known to be HIV positive, you don't know what the CD4 count is. Those good old-fashioned clinical surrogates, oral hairy leukoplakia, oral candida, seborrheic dermatitis, cutaneous Kaposi, all of these go hand in hand with a low CD4 count and epidemiologically go hand in hand with pneumocystis. That's the easy bit. You can still get pneumocystis with a normal CD4 count. 5% of a large series from my group had a CD4 count above 300. Not only that, the percentage CD4 count was above 20% of the total. So what I'm saying as a clinician is, you meet a breathless patient, don't be lulled into a sense of false security saying it can't be pneumocystis because the CD4 count is 320. Oh yes, it can. We're also seeing pneumocystis as an iris phenomenon. Tom's just talked about this phenomenon of clinical deterioration in the context of starting antiretroviral therapy. Soon after the Zalopa paper was published as an abstract at the meeting CROI, there was a meeting of the US Public Health Opportunistic Infection Guidelines Committee in Maryland. And at that meeting, this information around early start of antiretroviral therapy was discussed. Lawrence Huang, co-author of the Pneumocystis guideline with me, went back to San Francisco, said, right guys, we've been getting it wrong, we've got to start antiretroviral therapy early. And about 4 months later, he published his first 3 patients in the journal AIDS, all of whom he put into respiratory failure and required ventilation because they dramatically clinically deteriorated when antiretroviral therapy was started at 2 weeks. So be mindful of the sick patient with pneumocystis. Think twice about starting at 2 weeks. We've only ever waited till 3 weeks, and 7 days is not long in the fullness of time. We've never ever waited 6 weeks, and what a surprise, if you wait 6 weeks, some patients will get another opportunistic infection. The other presentation of pneumocystis is now a de novo presentation. So you have an asymptomatic patient who's been screened, is about to start antiretroviral therapy, starts it, and then develops PCP a couple of weeks later. Here is such a patient. Baseline, low CD4 count, moderately high viral load, asymptomatic at the time of starting, and then develops the onset of fever, breathlessness and hypoxia 3 weeks after starting heart. Bronchoscopy showed pneumocystis. Heart was continued, treatment was given with steroids and with co-trimoxazole, and the patient recovered. Cancer patients, any cancer patient with any form of cancer receiving a corticosteroid is at risk. Now the problem with the Carmona paper is it tells us which groups are at risk, but it doesn't give us a hazard ratio. So we can't do a risk analysis and say the risk of getting pneumocystis is outweighed by the benefit of prophylaxing, for example. But what I'm going to do now is just give you the headlines. The key thing with all these statements on this slide is a low CD4 count. So what I'm saying is there's an increasing evidence base for the utility of the CD4 count out with HIV in determining risk of developing pneumocystis. Rheumatology patients, well, we know from within the first months of starting these TNF alpha antagonists that there were reports of reactivation of tuberculosis and atypical mycobacteria. Well, hey, pneumocystis is up there in that risk statement now. This statement is particularly true for the syndrome that we used to call Wegener and that we now call granulomatous with polyangiitis. Any patient with primary immune deficiency of any of those subgroups is also at significant risk of pneumocystis. Here is something that is quite startling, and this data came out of a paper I published with colleagues in Oxford a few years ago. Any general medical patient receiving prednisolone, equivalent of 20 milligrams a day for 4 or more weeks, particularly if they have any underlying immunosuppressive disorder or even moderately severe COPD, is at risk of getting pneumocystis. Steroids, okay, well, let's cut back on the steroids. We'll give a lower dose of prednisolone. Let's put in a steroid-sparing agent. Unfortunately, even that strategy carries the attendant risk of pneumocystis also. So what about the diagnosis of PCP? Nothing's changed. Seeing it down the microscope is the best way, either by staining or immunofluorescence. The problem is the skill set, the laboratory skill set, is diminishing because experience is less than it was in the late 80s, early 90s. So there's a move towards using molecular diagnostics. I'd like to pay tribute here to the late Anne Wakefield. She and I published the first ever paper using molecular diagnostics for a fungal infection 25 years ago. In those days, we used a single round of PCR and then blotted and ethidium stained. Since then, we've got nested PCR, and since then, real-time PCR. We used the mitochondrial sublocus because it was easy to amplify. It's present in multiple copies. Other loci have been used. MSG, one of the major surface glycoproteins, is frequently used. Again, it's multi-copy, easy to pull out. And more recently, we've used heat shock protein 70 because we developed a technique to isolate specifically human pneumocystis using that locus. This is a meta-analysis of all the papers on molecular diagnostics for PCP, and it suggests quite a high sensitivity and specificity, but the specificity is not perfect. I'm going to elaborate on that point. Now, I've got some problems, and some of you who were at the FIS meeting recently will have seen me use this slide. I've got problems with molecular diagnosis. Ideally, if that patient in front of you's got PCP, and we use a molecular detection technique on sputum or lavage, if I detect pneumocystis DNA in that respiratory sample, I want the patient to have PCP. If I can't detect it, I want to be able to walk away and say that person hasn't got pneumocystis, they've got an alternative diagnosis. But there are two confounders: my skill or lack of skill in getting a good quality sample. And the best benchmark for saying it's a good quality sample is good old-fashioned microscopy. Are there alveolar macrophages there? And secondly, there's the patient factor. If the patient's sick, I need to be like the SAS. I need to be in there, squirt the saline out before the desaturation occurs. That's often not possible. So in a sick patient, I may get a very poor quality sample that's basically got respiratory epithelium in and isn't truly representative of the lower respiratory tract itself. Do we normalize the pathogen DNA to human DNA? And do we allow for a treatment effect? We know that most infections, in response to starting treatment, there'll be a rapid kill of those organisms. Can we still detect pneumocystis DNA after we've started treatment? Now, here's another confounder. This is Jim Huggett, who was my postdoc at the time, and he basically was developing this heat shock 70 protein assay for diagnosis of pneumocystis on lavage samples. And he amplified from 40 paired samples using different extraction techniques, and showed simply choosing a different extraction technique will dramatically increase the amount of available DNA that you can subsequently detect in a sample. Here is 62 patients with proven PCP, silver stain positive, treated with co-trimoxazole and or steroids, got better, and lavage showed no co-pathology, and over the next 3 to 6 months they did not represent with another respiratory process. Alongside that, in blue, are 74 patients with alternative diagnoses: bacterial pneumonia, LIP, Kaposi's, tuberculosis, nonspecific pneumonitis. These patients did not have any demonstration of pneumocystis by silver stain. They did not receive pneumocystis treatment, and again, over the next 3 to 6 months, did not present with pneumocystis or a recurrence of a respiratory process. Now, no matter where you set your cut point, you are going to either overdiagnose or underdiagnose pneumocystis. So what we're saying is the majority of patients with alternative diagnoses have DNA that is below the limits of detection or very low copy number. But some patients with other diagnoses are so heavily colonized with pneumocystis, the burden in terms of copy number maps beautifully to the copy number we see of patients with active PCP. Some groups have attempted to say, well, we can discriminate. Below a certain copy number, it's definitely colonization. Above another copy number, it's definitely PCP. But they describe a grey zone, and that grey zone in this publication is massive. It's more than 1 log and a half of copy number. So we're no further forward. We've just got to be aware that we need to take a positive DNA signal in context with the clinical presentation and be aware that we might overdiagnose pneumocystis in the immune-suppressed patient with a respiratory process. This was brought home vividly to me 2 Christmases ago when we admitted somebody we thought had PCP. Indeed, the molecular test was positive. Egg on face, they got better when we realized they had flu A. The silver stain was negative. So here's a paper from Joe Kovac's group at NIH. They looked at the MSG, the major surface glycoprotein locus, on the surface of pneumocystis present in multi-copies. Great news. Those patients with PCP had much more DNA detected in the PCR reaction than those that didn't have PCP. But if they sampled the patient after more than 1 day of pneumocystis treatment, the copy number fell off dramatically, down to levels you would associate with the diagnosis not being PCP. Now, conventionally, we've relaxed. We've said it doesn't matter if you start PCP treatment today, Saturday, and the patient's on the bronch list for Wednesday, because the silver stain will still be positive a week, 10 days into treatment. We can't adopt that strategy any longer if we're going to rely on molecular diagnostics, because there may not be DNA to detect in the lavage sample 7 days into treatment. Or if there is detectable DNA, it may be at the levels of the limits of detection, or give us a hint that actually it was a bacterial pneumonitis that's got better with high-dose co-trimoxazole, and there's a bit of background colonization. So it's just a word of caution. Diagnostics, these were reviewed in an article we published in Clinics in Chest Medicine just over a year ago. LDH is very, very poor specificity. I would not suggest you use this as a screening tool. Certainly in hematology oncology practice, I see much higher LDH levels in people who are about to start their chemotherapy or are ongoing with their chemotherapy, driven by the lymphoproliferation of the hematological process. Adamet had a vogue a few years ago in the States. A couple of groups reported low Adamet levels in serum or plasma, so this was highly specific for pneumocystis. Subsequent bigger studies have showed no correlation with depleted Adamet levels in blood and pneumocystis. I think beta-glucan shows promise. Here's a lovely paper from a reputable group showing it's got a really good sensitivity and specificity for PCP, over 85%. But hang on, the pre-test probability of them having pneumocystis was 70%. So this is not a proper study. This is looking at it. What's the sensitivity and specificity in people with a high risk of having PCP rather than unselected patients with a pneumonitis. This great meta-analysis may have escaped your reading. I really do commend it to you. It pulls together the data on beta-glucan and its usefulness. Now, what I found intriguing is, okay, there are a number of different assays, but colleagues who've published using these different assays have used different cut points for diagnostic sensitivity. So we need to be mindful of which study we're interpreting, which assay, and which cut point. Now, having said that, it looks like the sensitivity and specificity are pretty darn good, with a very strong positive likelihood ratio and a very strong negative likelihood ratio. However, just to make the point, not everybody with proven PCP will have a positive beta-glucan assay. Not everybody without PCP will have a negative beta-glucan assay, because other fungal processes, and indeed Pseudomonas has been reported as producing it, and it's been reported as being positive in people who've received immunoglobulin for other processes. There's a hint, a suggestion from a couple of publications, that those patients with a higher fungal burden are more likely to have a higher, more readily detectable beta-glucan assay. Here is an attempt from Olga Matos's group in Lisbon to say actually the LDH plus a beta-glucan adds to sensitivity and specificity. Actually, if you look at the sensitivity and specificity and the negative predictive value, they're no different whether you put the LDH into the mix or not. Treatment options. Well, we've got co-trimoxazole, nothing new there. It works, it's the best treatment. The problem is getting hold of it. Last night I had to agree to selling some co-trimoxazole IV to St Thomas's. There is a world shortage of IV co-trimoxazole. There is also a publication from the States, published a few weeks ago, suggesting they've had the same problem but have been treating pneumocystis with high-dose oral co-trimoxazole, and they are reporting inferior outcomes from the equivalent dose given orally. IV pentamidine is not as good and more toxic, but I put in here caspofungin, and I put it in red because I think there's still a little bit of a red flag around its use. I'm fully aware of Darius's publication in Thorax, the case series, where he used it in PCP associated with HIV. I'm going to tell you I don't think it works on its own, and I'm going to give you some evidence in a minute to prove that. If we're going to treat pneumocystis, measure the oxygen, please. The reason for that is we need to know whether it's severe disease, moderate disease, or mild disease, and the reason for that is some treatments just do not work. There have been trials, and they will not work in severe disease. Atovaquone, for example, will not work in hypoxic pneumocystis. Other treatment regimens, like dapsone and trimethoprim, have been tried. Again, they don't work. If the person's got HIV-associated PCP and they're hypoxic, we're going to give them steroids. What's killing the patient with severe PCP is not the burden of the organism, it's the ineffective human inflammatory response which they're drowning in, and they will die of respiratory failure from their human inflammatory response. So the steroids are attenuating that inappropriate inflammatory response, buying time for the antibiotics to kill the pneumocystis. There's less of an evidence base for using adjunctive steroids in non-HIV PCP, and indeed many of those patients are already on steroids as part of their underlying immune suppression or their oncology hematology regimen. The other thing to remember is before we say, oh gosh, this patient's failing their Cetrin, is on the road to recovery, it takes 4 to 7 days for the Cetrin to work, even longer for pentamidine. So we can't say somebody's failed Cetrin if they've been on it for 2 days. It's not time enough for them to get better. Now, this road to recovery statement is perturbed by using adjunctive steroids. You will recover more quickly if you receive adjunctive steroids, simply because your inflammatory exudate is attenuated, your gas exchange improves, your X-ray looks better. If you inappropriately stop the steroids after 4 or 5 days, the patient will relapse with a worsening inflammatory exudate and recurrence of hypoxemia. Before you say the patient's failing at day 6, day 7, make sure you haven't put them into pulmonary edema by giving them gallons of normal saline to dilute your co-trimoxazole. Make sure they haven't got a small pneumothorax. Make sure there isn't an intercurrent infection, co-pathology in the lavage, or a bacteremia. Make sure if you're using clindamycin, they haven't got methemoglobinemia. Make sure this isn't a consequence of Rob doing a bronchoscopy, and it's not just simply a post-bronchoscopy deterioration. Of 100 mils of saline I put into lavage a patient, I will get back 30, 35 mils. For the next 24 hours before that fluid is resorbed, that fluid will remain in the alveoli, flooding out additional alveoli. Embarrassingly, once a year or so, we find that despite being, we think, an infectious disease unit, the junior staff have prescribed the wrong dose of co-trimoxazole, and the patient's actually only been on prophylaxis rather than on treatment. So it really is important to get these things sorted out. I put the drug resistance there. Yes, we know where the drug target is, DHPS. We know that mutations are reported in people who've been exposed to sulfur drugs. There is no good evidence that actually having sulfur mutations in your pneumocystis confers a phenotypic statement of drug resistance. As I mentioned, pentamidine, almost as good, more toxic. Clindamycin, just as good as co-trimoxazole. Limited data in severe disease, but that's what I would use to change a patient to if they were failing Cetrin or they had adverse reactions to Cetrin. Dapsone trimethoprim, overlapping toxicity, doesn't work in severe disease, Atovaquone, you can only use that in sort of outpatient management. It doesn't work. What about caspofungin, though? This neat paper from Mel Cushion, part of Peter Waltz's group in Cincinnati, showed that the echinocandins actually deplete the cystic form of pneumocystis in rats and mice with an experimental model of pneumocystis, leaving the trophic form. The trophic form clearly couldn't propagate infection to other mice and rats in the laboratory, giving a hint that it's the cystic form that's the infectious form. Secondly, when they stopped the echinocandin, the lungs repopulated with the cystic form of pneumocystis. So it is not killing pneumocystis. It doesn't work on its own. And then this really neat paper from Olga Matos's group looked at, again at an animal model, and here I think this is going to be the way forward. One of the limiting factors about using high-dose co-trimoxazole is toxicity. Between 25 and 40% of patients will have to swap treatment to another regimen. And what these guys did was use low-dose co-trimoxazole. Rather than using 120 mg per kilogram, which is what we would use clinically, they used 75 mg per kg. And they combined it with caspofungin, and they got equivalent treatment outcomes to high-dose co-trimoxazole. Here's a paper. I'm interested because I'm not quite sure about the ethics of this, but this Chinese group gave low-dose co-trimoxazole and caspofungin to 3 seriously unwell patients with pneumocystis, and they got better. So to me, this is a future direction. I think this is possibly the way forward. Caspofungin and low-dose co-trimoxazole. What's new and cutting edge in the last few moments? I want to talk about air pollution and the way the body responds to pneumocystis. We know that air pollution perturbs various aspects of our innate immune system. Most studies of air pollution on the immune system have looked at single controlled exposures to one pollutant. And there are uncertainties about real-life exposures. We know in epidemiologic studies that household air pollution is associated with increased risk of bacterial pneumonia, ambient air pollution is associated with increased risk of hospitalization. But there's uncertainty about whether vulnerable populations like HIV-positive patients are susceptible to the effects of air pollution. San Francisco is great because the climate is well recorded, and this is a collaboration with Lawrence Huang in San Francisco and Peter Waltz in Cincinnati. So this is looking at patients admitted to San Francisco General Hospital with proven PCP. The Environmental Protection Agency monitoring station is less than a kilometre from the back door of the hospital. 95% of residents in San Francisco live and work in the same zip code. So we chose an area around the hospital, very well defined geographically, and we looked at various parameters of air pollution. And we measured these a couple of weeks before the time of hospitalization from records and at the time of hospitalization. We looked at the immune response in those patients to the major surface glycoprotein. MSG's got 3 overlapping segments, and I want you to look at these statements down in the C end of the protein. And what we've done is we've measured antibody responses to recombinant antigens made to those C end fragments. And we've measured, using ELISA, the IgM response to those recombinant fragments. The headlines are that air pollution, particulate matter below 10 microns, and NO2 are associated with an impaired immunological response to pneumocystis. So what I'm saying is real-time, real-life exposure to air pollution is being demonstrated as impacting on the human ability to respond to pneumocystis. I want to talk about pneumocystis in the airways in the closing seconds. This work from Alan Harmson. He exposed 2 strains of mice to pneumocystis for the first time in their lives. And essentially, they had an acute, allergic, airways-based response, with airways responsiveness increasing and with marked upregulation of mucin genes and expression of mucin. So this, for the first time, is saying actually pneumocystis is interacting with the airways, not just with the alveolus. We're comfortable with the latter statement Pneumocystis, dectin molecules, binds in the alveolus, produces an inflammatory response, eats surfactant, propagates. Here we're saying primary exposure to Pneumocystis provokes an inflammatory response. Sudden unexpected infant death is a very emotive subject, and there are many factors that can associate with it. Infectious causes, inborn errors of metabolism, cardiac channelopathies, poisoning and overdose, accidental suffocation, and the syndrome of sudden infant death. Sergio Vargas has previously identified low levels of Pneumocystis in the lungs of infants dying of sudden unexpected infant death. Patchy infection peaking at about 2-3 months, which correlates with the peak of incidence of sudden infant death and with the incidence of things like viral bronchiolitis. In this study, which I collaborated on, all the children dying in Santiago City have to have a post-mortem. It is a legal requirement. The coroner insists that any child dying in the community has to have a post-mortem. We looked in the lungs of these children by PCR and immunofluorescence for Pneumocystis. And we also looked at mucin expression, and we tried to measure, if we found Pneumocystis, its burden by quantitative PCR. What we found is there was almost universal presence of Pneumocystis DNA in the lungs of these children. Even looking by different categories, if we found there was a cardiac abnormality explaining the sudden infant death, they still had Pneumocystis in their lungs. Over 80% of all the kids. What we found is detection of Pneumocystis peaked at around 3 to 5 months. We also found that the burden of Pneumocystis was greatest at 3 to 5 months. We also found that mucin was upregulated in those children with detectable Pneumocystis, and was less upregulation was detectable in those without Pneumocystis. Further, the bottom part of the panel, we found that that upregulation of mucin expression was independent of the burden of Pneumocystis in the lungs. So what I'm saying is, I think, with or without viral priming, with or without co-pathology, primary exposure to Pneumocystis in a child, few weeks, few months old, produces an allergic reaction. And we know that expression by a goblet cell of one granule of mucin within one respiratory cycle, that granule will expand 100-fold in diameter. These kids are dying of drowning out in their own mucin. At post-mortem, the pathologist says, oh, well, there's a bit of mucus in the airways, looks for Pneumocystis, there's no pneumonia, and by PCR you find there's low-level DNA, and occasionally by immunofluorescence you find the organism. So Pneumocystis is caused by Pneumocystis jirovecii in humans. We still benchmark diagnosis by conventional diagnostics. Word of caution about molecular diagnostics. Beta-glucan, I think, shows promise, and I think we're going to be talking in a couple of years' time about new strategies for treatment based on low-dose co-trimoxazole and caspofungin. And finally, slightly contentiously, I think Pneumocystis may have a role in the etiopathogenesis of sudden infant death. Thank you.